So how important actually is first pass recanalization? My disclosures, I don't think they affect the content of this talk. So essentially, what do we consider to be a success of thrombectomy? Is it just a recanalization, a meaningful, like TK2? Is it TK3, or is it TK3 at first pass? And this was mentioned already by Marc Ribot in his talk, this European guidelines, and they are about to be updated in the end of this year after all the IV TPA studies have been published. That was mentioned by Dr. Savello already. And about the recanalization, the recommendation is that TK3 reperfusion should be the goal of thrombectomy, if achievable with reasonable safety, in short. And reperfusion quality is the most important modifiable predictor of patient outcome. So this is what we have in our hands. We don't have in our hands how large the infarct is. We don't know. We cannot influence a lot how much time has elapsed from patient's symptom onset to the hospital, but we can influence the logistics of the patients, and we can influence the reperfusion quality. And a very important practical question is, and this is what I would like to address here, when to stop a procedure after incomplete reperfusion. That's a difficult one. So that's really hard to decide based on current data. And the research question is, how do we achieve the highest rate of TK1 at first retrieval with the lowest number of passes, essentially? So this is the definition of the first pass effect. It has been coined by Sam Zeidat, and it's defined as complete recanalization with a single thrombectomy device pass. And he summarized TK2C cases together with TK3 cases. And the clinical outcome is very clear with first pass effect, with very good reperfusion at the first retrieval. You have much better clinical outcome, more than 60% good outcome compared to non-first pass effect. But that's not necessarily the whole truth. You have first pass effect, 61% good outcome, any TK3, 55% good outcome, and any TK2B, 44% good outcome. And at the same time, the mortality rises with each step in reperfusion quality. So if you directly compare the first pass TK3 only, so only TK3, not TKC together, and multiple pass TK3, you have a significant difference. So it does matter how many retrieval maneuvers you need to achieve a perfect recanalization result. So far, it's clear. And again, this is from Marc Ribot's group. Again, has been published about 2 years ago. So with just one retrieval, you have 60% good outcome, and then it goes down stepwise with each retrieval, additional retrieval required. So this is a very nice study. And it was also related to the location. So M2, higher rate of recanalization, and so on. So this is what is established. And overall, if you look at the literature, you can see a nice development in reperfusion quality. So this is the dark green ones. So these are 100 patients, and the dark green ones are the ones with first pass TK3, the lighter green ones with any TK3, and the very light green ones with TK2B, and the yellow ones TK2A, and red ones TK001. And if you look at the Hermes group, so all the studies that we rely on for our recommendations, they had a relatively low number of first TK3 overall, and we don't know the number of TK3 at first pass. Then this is our own data, so it's better, but the NASA data are still better than our data from our hospital. And this is from the ERASER study that we published 2 years ago. So it's kind of growing the percentage. So here we have about 30%, almost first pass full TK3. But in my presentation, I would like to focus on this data set, which is the German stroke registry. And I think this, because this is, I have direct access to these data, and we did some publications based on this, and I think this helps nicely to explain the problem and maybe give some of the answers that we wait for. So this data set has now more than 10,000 patients, but for our analysis, only a subset from 2015 to 2018 was included. And this is the analysis we published early this year with 2 papers. This is one of them. So this is the success rate at each retrieval. So this means at first retrieval in these 25 German centers, on average, we had a 40% success rate with the first retrieval. With the second retrieval, we had another 20%, so overall 60%, then another 12%, and so on. So this gives you the cumulative rate of TK2B. And this is, at the same time, the rate of good clinical outcome, also cumulative. So overall, we end up with about 40% good outcome and 82-ish percent of good recanalization. What exactly does this mean for the patient? So this is MRS at 90 days. So 0 means no clinical symptoms at all. And here you see the rate of patients that are green here are the ones with good clinical outcome. Obviously, it goes down, just like the colleagues reported from Barcelona. And here you see a bit more of the distribution here. And because the numbers are much higher, you have more, can make more clear estimates of what the real numbers are. And what you see here is that the mortality also goes up. So it's almost 50% if you have 6 retrievals or more. So this is what we all would expect. And this, again, the Barcelona chart from 2019, and this is the German stroke registries chart, the percentage of patients with good clinical outcome with TK2B3. But now it's getting more interesting. What we have here are the patients without recanalization. And this is, let's say, the first retrieval. And this is the patient that had just 1 retrieval, and the procedure was finished with a non-success, but nothing was done later on. And this was a first pass success. And these were the patients where no recanalization attempt was performed whatsoever. So this is kind of our baseline. So, and if we compare this, we have a difference between no recanalization and recanalization. And the interesting part is, of course, the number of good clinical outcome or the percentages goes down, but at the same time, it also goes down in the non-reperfusion group. So there is always an advantage of doing the reperfusion. And I think that's a very important information, because you could say, okay, theoretically, after the 5th retrieval, we could say, I don't do anything anymore because I do only harm. So theoretically, it could be the case that the rate of non-reperfusion has a better clinical outcome than reperfusion, but this is not the case. I don't exclude that there is a subgroup of patients with negative outcome. I will come back to this in a minute. But these data really suggest that at any time of the procedure, it's better to have a reperfusion than to have no reperfusion. And if you do a proper statistical analysis, you see here that only to the 3rd attempt, it's better than no attempt. Then after the 4th attempt, it's worse, essentially. So this is also true if you do a proper statistical analysis of this whole thing. So theoretically, only if you achieve recanalization after 3 attempts, you have a better result than no attempt. But if you have at the third attempt no reperfusion, it doesn't mean you can stop, because you are now much worse than if you hadn't done anything at this moment. So probably you should move on and try to achieve a reperfusion if you think you have a safe bet. But after all, we need to be very cautious with the interpretation of these data, because we don't know why the procedure was stopped at this different phases after the third or fourth. So if we want to have a real answer, we should create a randomized trial that includes all the patients who had 3 unsuccessful thrombectomy maneuvers, and then either we stop or we do something, and there are some bailout devices, stentings, and so on. So I think there are some studies in the making on the subject. So this is not the final word, but I think it's interesting to look at it for our decision making at the moment. So if we discuss about how harmful is trying, so there has been, I think a week ago, this publication, so on April 29th, from the Canadian, the Calgary group, and they compared 260 patients with failed thrombectomy with those where no endovascular therapy was done, and they showed that there was no difference. So a failed reperfusion was as good as no reperfusion attempt. So all these patients where we tried unsuccessful to do the reperfusion, same outcome. And in fact, we did exactly the same a little earlier in October, and we found the same thing. So TICI-2A, so unsuccessful reperfusion attempt, had no difference in the median outcome with no treatment. So we don't make patients worse, but we always, if we achieve success, we make them better. So that's we always give them a chance, never 100%, obviously. But if we try, there is no harm in trying. So I think that's a very valid statement for the moment. And now, what's the point after all with all these retrieval attempts? So from our study again, is it just the more retrieval attempts, the longer the time we need, or what's the reason? And I think that's very nicely illustrated here. So this is all the patients with one retrieval attempt, and one retrieval attempt can be very quick, so 25 minutes or 10 minutes or whatever, or it can be even 150 minutes because there was a carotid occlusion and a lot of work and a difficult arch. And if you look at this, the rate of good outcome, if you just need one retrieval, there is not much change. So let's say this is 40% good outcome. So this is 50-something%, and then we have 45. So there is not much difference dependent on the time. So the number of retrievals is more important than time. So, and if you look at if you need 2 retrievals, so the same quartiles, there is not much of a difference. And okay, overall, something is going on here, no doubt about this, but the effect size is smaller than the effect size between the different number of retrievals. So I think I skipped this one, but this is going in the same direction. Another paper of the same cohort here. So this is the odds ratio for getting a symptomatic intracranial hemorrhage. So complication, the worst complication we can imagine in an acute situation. The minutes from symptom onset to groin puncture and the minutes from groin to final TICI have no effect whatsoever on the chance of getting intracranial hemorrhage as a complication. But if you have more than 3 passes, that's a significant effect. So again, the number of passes is a different story than just another way to express the time from symptom onset. And you can look this up also here. actually the highest number, or the highest absolute count of symptomatic hemorrhages was after one retrieval. But if you put this into perspective of the number, it's low. So the highest relative percentage of symptomatic hemorrhage was observed after 4, 5, and 6 retrievals. So more retrievals, more risk, obviously. So how do we come to a better first pass effect? So number one, and this was already mentioned by Mark, combined techniques. This is not very new. So we have all these different acronyms, SAFE, CAPTIVE, PROTECT Plus, ARTS, whatever. There are more that essentially are similar in the sense that they combine large volume intracranial catheter with a stent retriever and aspiration, and they have a better recanalization rate and obviously also better clinical outcome. But this is not finally, let's say, confirmed, but I think there is little doubt that this is the case. And another potential pathway is this one, so very large distal aspiration catheters, so 088 ones from some companies, or also the large ones from Penumbra, and completely different technologies like this one that we tested in the lab. So I think there's quite an exciting development on the aspiration side, but this is still too early, and there are still no very reliable clinical data on this. But I think that's very promising. And another thing that could be very promising is this recent development of looking at the anatomy. If you have a regular occlusion or irregular occlusion, and it seems that they have a completely different response to aspiration and stent retrievers. So the regular ones are more susceptible or prone to be successfully treated with adapt aspiration, and stent retrievers seem to work better in the irregularly shaped. But this is a subject for another talk. So if I may summarize here, it's absolutely clear that we should try to maximize the first pass effect. So TICI-3 at the first pass delivers the best outcome. And if you have 1, 2, or 3 attempts, it's significantly better in terms of good clinical outcome and lower symptomatic intracranial hemorrhage rate than no attempt at all. So we also can try. If we look at these data that I showed to you, there's probably no good data on when you should stop. So at any given time, it's probably better to achieve recanalization than no recanalization, but it's obviously we should always take the risk into consideration, think about the increasing symptomatic intracranial hemorrhage rate and optimizing the first pass effect. How do we do that? Probably for the time being with a combined approach or with the promising new development of third generation aspiration tools, and also maybe a more tailored therapy, aspiration or stent retriever based on the angiographic anatomy. Thank you.